Hello, everyone. Welcome to episode 211 of the 98 Crisis Jam learning community. We're very happy to have you here today. I'm Dr. Chuck Browning. I'm CEO and president of Behavioral Health Link and the chief medical officer of strategy at Recovery Innovations. This is season 5. As we're moving forward, we're going to connect and tell you about some of the cool things that we have coming up, but let you know a little bit about our speaker today. I'm very excited for Dr. Morgan Shields. Who's going to be kind of an expert and does research in quality and especially and focuses on inpatient care. And I've seen the preview to the talk and the slides, and I'm really looking forward to her educating us, teaching us a little bit about the care perspective of quality and inpatient psychiatry, as well as the hope of continuing to change and evolve that for improvement of the better. That speaks near and dear to my heart, and I know to a lot of people on the Jam. This will now be over 500 unique speakers over the 5 seasons and 200 plus episodes. So just remember, if you have any idea for a future topic, please connect and do that. We have so many speakers that we could not fit Morgan in yet, and we're gonna have to redo this list of names. But as you can see, we've still got her listed in, and she'll be somewhere right in there between David and Kristen. And as always, we our Crisis Jam Learning Community website where you can see lots of information in past episodes. There's now a live stream feature where you can watch it directly from the talk.crisisnow.com community, as well as being able to go back and review past episodes, past articles, any other videos and materials that were placed on here. You can get your virtual background that I have posted here in the back behind me as I'm in my hotel room down at the bottom. Thank you for getting that to me, Kristen. And also has, like I said, the past episodes. Last week on episode 210, we had a No Wrong Door chat with Dr. Chris Carlson. So I think that's a really nice segue into what we're going to talk about today in inpatient psychiatry, because as you do No Wrong Door, and work on being able to say yes to everyone, how do you make sure that you still keep up a level of care that you would want your loved ones or family ones or yourself to experience? So I'm really looking forward to sharing and talking about that today. Did I say Dr.? Oh yeah, it said Carlson instead of Dr. Chris Carlson. Correct. Thanks for correcting me on that, David. All right, so in the latest crisis news, we're going to show you there's a 6-minute clip that was released with some of the changes going on and streamlining the HHS to make the agency more efficient and more effective in the plans of the current administration. And that includes moving different segments of different entities into a new organization called the Administration for Healthy America, or AHA. And so there is going to be posted in the chat lots of different news articles and news links, including a link to the full 6-minute audio. However, we are going to play just a 1-minute clip from RFK Jr.
I have some good news, though. As part of President Trump's DOGE workforce reduction initiative, we're going to streamline HHS to make our agency more efficient and more effective. We're going to imbue the agency with a clear sense of mission to radically improve the health of Americans and to improve agency morale. We're going to eliminate an entire alphabet soup of departments and agencies while preserving their core functions by merging them into a new organization called the Administration for a Healthy America, or AHA. We have 2 goals. The first is obvious: to save the taxpayer money by making our department more efficient. And the second is to radically improve our quality of service. I want to promise you now that we're going to do more with less. No American is going to be left behind. Our key services delivered through Medicare and Medicaid, the FDA and CDC, and other agencies will enter a new era of responsiveness and a new era of effectiveness.
So like I said, that's just a 1-minute clip of some of the details that were shared earlier this week. But feel free to be able to look at the many different articles in the chat, as well as the full 6-minute clip. So in the latest crisis news, The Suicide Prevention Resource Center released some of the state infrastructure success stories that are going around. And as you can kind of peruse that list and take a look at it, there is a lot of it about crisis and improvements and innovations and work done in crisis. I was going to say, Megan or anyone have any comments about any of those that are listed there? Don't think I see Shelby on here to see if she's here. If so, no, I don't see Shelby on here. So as you if you tuned in several weeks ago, we had our first live and location work at Salt Lake City and the Huntsman Mental Health Institute, touring around both inside and outside and seeing all the interesting changes, innovations, and improvements in this crisis receiving center, and it designed to really help support the community. I think they use the term of having like a warm blanket for people. So again, a focus on the work to be able to improve care systems and improve care. And it's going to really feed and work into some of the things that I think we're going to hear from Dr. Shields. In the near future, we're also going to be, don't have the exact date locked down. It's probably late May or June, but we'll also be doing a second live and on location tour. The Adam H. Board of Franklin County team will be leading that, and they've constructed an investment in over 59.9 million in the community to create a 72,000 square foot crisis continuum service that includes urgent care, some short-term beds, inpatient beds, as well as 23-hour observation beds, as many as 60 done. And the way that they've created that center to be designed to really improve the guest experience, the person's experience who's receiving care, their connection to the community, both in terms of family and people they'll be working with. It's going to be really interesting to see, and we're looking forward for you to see another community that's really stepping up the game of the way to do this when people need a safe place for help and some of the options and things that you can do. It's a beautiful building, but it's also designed to improve care just in the function of how it's set up. One other feature before I discuss the Crisis Jam I will mention about that is they've also enhanced and worked on being able to improve the ability to manage medical comorbidities and things that sometimes prevent people in crisis from being able to immediately get access to care by having to go to an emergency department or things like that for medical clearance. And so they have really stepped up the involvement of the medical and physical health supports there so that minimize even further people that only have emergency physical health care issues that would need to go to the emergency department versus being able to just say yes to them at the door. So stay tuned. We're thinking late May or early June is when that episode will be. And in terms of Crisis Jam debates, I had the fortune of being the moderator for one of our previous ones, but we've got some really cool ones lined up. I'll share with you some of the next ones. So I think it's 2 episodes from now. So in 2 weeks, we'll be having debate number 6, which will be mobile crisis should always be dispatched by the local 988, with Justin Chase from Solari and Preston Looper from Full Tilt being able to argue the pros and cons of that. And then in debate 7, we'll have the debate over all states should enact legislation that includes a 988 fee. And we'll have Hannah Weslowski and Tom Betlock being able to talk about that. And then just as a final follow through on the jam between Dr. Margie Balfour and Travis Atkinson on crisis facilities should receive voluntary and involuntary referrals. The most common response of yes was a 36%, but with definitely yes of 33%, we had 69% total that in the follow aftermath of that said crisis facilities should take both voluntary and involuntary referrals to be able to have a greater support system and structure. So a significant majority of the folks answered either yes or definitely yes. And now to our hot seat. So this again leads into the experience of people in crisis that go to a facility and what is that like? And so our lived experience library segments have been inspired by William Styron's breakthrough 1990 memoir, Pain, Darkness, Visible, in which he describes his near fatal struggle with depression. So for our questions for the audience today, according to Styron, what factor most contributed to his eventual recovery? A, medication that finally stabilized his mood. B, time spent in a psychiatric hospital. C, wife's support and power of human connection. Or D, a newfound spiritual awakening. So we'll let everybody submit their answers. Okay, let's walk through these a little bit, see what the answer are. We've got a new feature that we've actually got a little bit of discussion of each of some of these answers. So in terms of medication, at least in his experience, he found the medication ineffective and even frustrating. So that was not one of the answers. He did not identify the psychiatric hospital time spent as as the factor that most contributed to his recovery, but he did label it for his experience as a safe haven where he could rest, sleep, and begin to recover. He met some other folks that were caring that he felt was a piece of that, and it was essential in halting his spiral, but he doesn't identify as the main reason and cause. So let's see, that leads it down to wife support and power and newfound spiritual awakening, and the answer is C. So for his experience, while medical interventions and rest did matter, it was the unwavering support and love from his wife, Rose, and others who surrounded him with care that ultimately kept him tethered. Love, quiet, steadfast, and human was the most vital force in pulling him back from the brink. So I do think that segues in a great way into some of the things that Dr. Morgan Shields is going to be talking about with us. Because one of the things that, as we look at some of the things that he said, and we've had, several segments about no wrong door, and we even debated about that between can you do voluntary and involuntary. And some of the talk was about that if you do involuntary, that it definitely means it can't be a caring environment. And so I think, or that setting can't be caring. And so I think one of the things that as a take home as we talk about this is to think about, let's not confuse the setting with the solution. And so think about the overall solution, no matter what the setting is what is that experience, and is it effective and helpful in helping people improve from their crisis? So with that, I'd love to introduce Dr. Morgan Shields. He's an assistant professor and director of the Ideal Lab and has a specific focus on research and quality, especially in inpatient institutions. And so, Dr. Morgan Shields, thank you so much for being with us. We're looking forward to hearing you teach us some things today.
Yes, thank you so much for having me. I'm excited to be here. So I'll just say next whenever I want to go to the next slide. Okay. So I am an academic researcher, and most of my research has focused on the setting of inpatient psychiatric care. Although I am starting to become a bit more interested in crisis services more broadly outside of the hospital for a variety of reasons. But I'll start by just saying that my interest in the topic of inpatient psychiatry is connected to my own lived experience. So I have direct lived experience of inpatient hospitalization, several experiences that occurred when I was in a state of mania and was experiencing psychosis. And then I also have experience as a loved one. And so it was this lived experience. Next slide. Thanks. It was this lived experience combined with my realization that there's very little empirical evidence on inpatient psychiatry, at least in the United States. There's a bit more in other countries. That led me to just be curious about variation in care quality, right? Because I had my own experiences that seemed to vary, had some pretty bad experiences and some that were not that terrible. I wouldn't say they were amazing. And the same with my loved ones. So I was curious about how does care quality vary? How would we even measure care quality? And why does it vary? Does it have something to do with the ownership structure, the staffing? What is it that explains this? And then how might we go about systematically improving care quality? And these questions are, okay. Well, I'll just it's okay. I'll just say that these questions are pretty typical questions in general health services research. And so I would characterize myself as a health services researcher. And I thought, okay, I'll just ask the same questions that everyone is asking about, treatment for heart attacks, or et cetera. We'll just copy and paste and ask the same questions in a setting where not many people have asked these questions. Next slide. But throughout the past decade or so of doing this research from when I was a student, I've come to discover really that the issues of inpatient psychiatry require deeper questions than just trying to understand variation in care quality, which I'll get to at the end of my presentation. But for one, there is limited evidence to suggest that inpatient psychiatry provides net benefits to people. And this is evidence that researchers have been trying to produce, at least globally, since the 1950s. And shockingly, the risk for suicide is highest following discharge from inpatient psychiatry, about 258 times the general rate within the first week of discharge, 180 times within the first month. And while some of this risk might be due to selection, where people who are more at risk of suicide are more likely to be hospitalized, right? So that makes intuitive sense. And we don't really have a counterfactual to compare to. There is reason to suspect that some of this might be related to iatrogenic harm caused by the hospital itself. And so when I think about how might the hospital cause harm, there are various different mechanisms I think about. So for example, medication disruption, right? So this is oftentimes short-term hospitalization, and people are taken off meds or put on meds. There's a disruption there, and then they're discharged. There's also life disruption, so losing a job, housing, discord with loved ones. But also this might relate to interpersonal treatment with the frontline staff, as well as how people are treated in pathways to the hospital. Next slide. So in my research, so I've done quite a bit of research now, both survey, quantitative research. I've done focus groups, one-on-one interviews. So for my research, as well as research conducted primarily in other countries, what jumps out is that people with lived experience point to their interpersonal treatment as being the most important aspect of care quality. So when you ask them, were you satisfied with your treatment, and what aspect of your treatment impacted your satisfaction, it's really their relationship with frontline staff, as well as at times their relationship with other patients, that's sort of the peer relationships. And so when people have interactions that are felt as dehumanizing or perhaps even terrorizing during a moment of vulnerability and fear, this can lead to harm, right? So you can imagine how that might lead. This could be a traumatizing event for people, and that there can be cascading consequences within the hospital, right? So it can lead to also restraint intervention, so physical harm, right? It can cascade, and then it can cascade into distrust and lack of engagement in post-discharge care moving forward. Next slide. So for folks who were at CrisisCon, maybe you've seen some of these slides, and I probably could swap out these quotes. I have so many really compelling quotes, but these two quotes I'll share with you, I think, do a good job of capturing the points that I'm trying to make. So the first one, I will never go back to a mental health facility ever again, even if it means I end up killing myself instead. There is zero trust there, and it felt like I was in prison. So this is the opposite of what we would hope would happen to someone who's hospitalized, right? Who's maybe already on edge. Next slide. This one, I watched techs bash patients' heads into the ground. They literally ignored the one woman who repeatedly kept talking about how police were going to come kill her because her brother was the Messiah, past child sexual abuse. And for me, I wasn't allowed to have underwear or clothing for 3 days. So with this quote, I really want to highlight, which I think most people on this call probably can appreciate, but this is a population that has, high prevalence of trauma, including sexual violence. And this is a setting where it's not uncommon for people to not have access to their clothing and underwear, and to experience or witness violence. And then there's also this aspect of just ignoring a person or who might not seem to be in touch with reality, but this sort of not viewing a person as fully human or worthy of engagement or human connection if they're not seeing the world the same way that you are. Okay, next slide. So here I'm showing regulatory complaints to the Department of Mental Health in the state of Massachusetts, which I show to further contextualize that the floor for quality is very low in this setting. And the quality issues extend beyond just quote unquote medical error. So when we think about patient safety or quality of care in general hospital care, really we think about error, so we need to have checklists. We need to have efficient teams to reduce misdiagnosis, or giving someone the wrong interventions or the wrong meds to reduce error. But what I have found in my research, and I think these complaints really sort of speak to that, is that a lot of the quality issues, while error is definitely at play, extend beyond error, or actually caused by the way these services are designed fundamentally, and actually speak to human rights violations. So next slide, just so I can highlight. Okay. So I'm highlighting a few of these complaints. So across 70 facilities in about 11 years, there were over 2,000 complaints related to physical abuse, over 1,000 related to verbal abuse, about 1,000 related to sexual abuse. And there were 576 medical legal deaths, and these are deaths that required investigation. It does include post-discharge deaths to the extent that the department was made aware of them. And I did check these data with the Commissioner of Mental Health at the time, and she said that the numbers looked accurate, because I was actually quite shocked and thought maybe I was made an error in my counting. What I want to emphasize here is that these incidents, especially abuse, should be never events. So you can't really argue, well, a little bit of abuse is to be expected, or maybe some of those hospitals have sicker patients and therefore that's why they have higher rates of complaints and abuse. These should not be happening regardless of an individual's condition. And that is a debate that happens with restraint and seclusion, right? So some people will argue we can't ever achieve zero restraint. You need to have a little bit of restraint with sicker patients, but that sort of logic doesn't apply to abuse. And the other point I want to make is that these are incidents that were reported and made their way all the way to the state regulator. So they're not a measure of actual frequency, and actually they should be viewed as just the tip of the iceberg, right? Okay, next slide. Okay, so when we consider the context of inpatient psychiatry as being one of extreme power imbalances, we actually shouldn't be shocked that there are issues with care quality and human rights violations, right? So just through a lens of stigma, this is a patient population that's viewed as less than human, and these institutions just sort of further that divide and that othering, right? And then also this is a market-based service in the United States, but there are huge market failures. So just in short, providers don't really experience consequences for providing poor quality of care in the same way that they would if they were selling shoes, or even if they were a primary care provider. So the actual end users here, the patients themselves, don't have access to quality information to be able to make informed decisions. And even if they had access to that information, they can't use that information to make decisions, right? And this is compounded with the use of involuntary hospitalization, which is unique to inpatient psych compared to other hospital settings. A family can't easily be at the bedside to advocate for patients like they can in other settings, and patients can't easily self-advocate either due to their condition or medications they might be on, but also their perspective of reality is just discredited, and they might be scared that they're going to be punished or held longer if they sort of put up a fight. So next slide, when we consider, if we just map out power imbalance and vulnerability, we should anticipate that we need to have robust accountability mechanisms. But I would argue that the opposite is true, is that actually this is a setting where we have a lot fewer accountability mechanisms than we do for other healthcare settings. Next slide. So, for example, regulations and enforcement. So if you were to look at state regulatory language, CMS's conditions of participation language for psych hospitals, or psych facilities, I should say, it includes units and general hospitals, or the Joint Commission language, which accredits most of the psych facilities. Almost all of the language is really oriented around safety. and really physical safety, access to ligature points, et cetera. There's not a lot of language specific to trauma-informed care or the actual therapeutic value of the service. Psych patients are also excluded from national data sets. The HCAP excludes psych patients and children, which is a measure of patient experience, and doesn't exclude any other patient on condition of their condition, just psych patients. CMS has recently adopted a measure of patient experience for their IPFQR program. So that's interesting, and we'll have to kind of see how that gets rolled out. They're in a voluntary reporting period right now. Psych hospitals were excluded from CMS's EHR incentive program. There's some evidence that even within general hospitals, the psych units don't adopt the EHR functions in the same way that the rest of the hospital might. And then there's a lack of dedicated data systems and regulatory clearinghouses, which do exist for nursing homes as sort of a comparison. Next slide. So what I just went over, those are examples of structural discrimination, structural discrimination. And they may also, though, relate to the advocacy landscape in our country. And this is what I'm really interested in, and I spend a lot of time thinking about, and I'd love to hear people's thoughts on this. So a system in a society will not, spontaneously just improve accountability without some sort of pressure. So either that pressure comes from the market, there's a demand response, or there are dedicated advocates and journalists, right? There's some sort of pressure that's happening. And currently, and this is just my opinion, actually, so I'll be clear about that. What I see is that there are two active advocacy camps when it comes to the role of the hospital in our society, and they are on two ends of the spectrum. So they're either pushing for expansion of inpatient psych, more beds, with very little mention to quality of care, or abolition. And I'm sympathetic to the abolitionist perspective, just to be clear. Their worry is that if we start investing in reform of the hospital, that will divert resources away from community-based services, which might be true, right? Next slide. And next slide. I've been curious, to what extent can we have synergy between trying to build up alternatives to the hospital and community-based services and prevention, but while also improving accountability of the hospital, because these facilities exist, they actually are expanding, and there are lives that are being impacted. And so if we just totally neglect this setting, I sort of view it as harm reduction in a way. And then it is a question, can we ever have a society without the hospital? So next slide. Oh, I don't have to go over this because I know we're short on time, but just to say, this is showing that there's actual variation in patient-centered care experiences, and this is strongly associated with trust and engagement in care post-discharge. I don't know to what extent that the fact that there's variation in experiences suggests that it's possible to systematically reform the hospital in a way that's equitable. I'm not sure, but one might say that this is a signal that, wait a minute, it's not the case that everyone's having terrible experiences, and maybe this gives us some hope that we can figure out how to pull up the poor performers to be at least at the same level as the higher performers. Next slide. And so I'll close my presentation by just introducing some revised questions that I now think about. So I am still curious about variation in care quality, sure. But now I do question the fundamental role of the hospital in society. And is reform even possible? Is it possible logistically, politically? Is it more just to focus on implementation of alternatives? Is abolition of the hospital, the psych hospital, the only quote unquote right orientation to the problem? And especially when we think about neglect, right? So my concern is that if we abandon reform of the hospital, are we just abandoning the folks who are experiencing that care and neglecting them? I'm not sure. And next slide. I'll end by just saying I took a trip to Trieste, Italy in October, and it was life-changing. And that is a community where they actually have successfully deinstitutionalized. It's rights-based, it's community-based, and actually relationship-based and trust trust-based. They really get the value of building relationships and trust with people, even when they're in their most extreme crisis. And so that gives me hope that it is possible to move in that direction, and that should be our North Star. And we should be trying to move in that direction. But it is a pragmatic question. To what extent is this possible in the United States? I'm not sure. So thank you for your time.
Oh, Dr. Shields, Morgan, that was just fantastic. Really spoke to my heart. It's a big philosophy of where we work, is to try to find that synergy that you discussed about being able to say yes to everyone, but still in you making an experience that's caring. And the way that you worded it, gave information and facts about it behind it was just phenomenal to me. So very much appreciate those insights and sharing. And so on our roundtable, I'd like to introduce, we're going to have two folks on our roundtable, but first we're going to start with Shireen. Hey, Shireen, it's good to see you.
Hi, Chuck. It's great to see you as well.
And so she's the Chief Executive Officer and Chief Global Strategist for the Promise Resource Network, lives in North Carolina with me, and is just a amazing advocate with her lived experience and a voice to others about changing that experience and creating a humanizing experience of care, in my opinion. So thoughts on Dr. Shields' presentation, Shireen?
Where do we start? So first of all, thank you so much, Dr. Shields, for inviting me to come to this dialogue. And thank you for sharing your own shared experience. I think it's really important for people to recognize that those of us with lived experience encompass so many different backgrounds and professional expertise. And it's not until we start talking about it that we start destigmatizing and demystifying the experience of mental health within our own system and within our community. So I just want to say that I honor the fact that you did that, and I really appreciate that. I do want to give a little bit of context, because I am coming in this with experience and bias, and I want to name it right from the bat. Dr. Shields and I were actually in Trieste together, which was great because we got to see firsthand how they did eliminate the use of hospitals in that setting. As a matter of fact, the hospital I went to had 6 beds for a population of 350,000 people. And the hospital was open access. It was 0 involuntary commitment. As a matter of fact, they tried to minimize, if not completely exclude, involuntary treatment as an option. And therefore, their hospitals are actually open access. We'll get back to Trieste in a minute, but we both had that wonderful opportunity to see firsthand what it looks like when you right-size a hospital system, but what it also takes to create a hospital system that is much more inviting and comfortable and welcoming, that is not sort of the tension that we have in the United States, where people are being just forced into confined spaces with the illusion of safety as the outcome. So some of the bias I want to share. My first role, I've been doing this work for 32 years, and my first professional role was working in a psych center, a short-term acute care psychiatric center for children and adolescents. And since then, I've worked in and with many hospitals around the country. And I will tell you, I have spent the majority of my 30 years trying to prevent hospitalization. And that has looked like a lot of different things. I've worked on reform efforts in hospitals. I do not believe that we are going to abolish hospital systems. And there are a lot of reasons. We have a lot of for-profit organizations that are coming into play with hospitalization. There's a lot of incentives. There is a belief system continued within our mental health system that people need to be confined against their will. As a matter of fact, I think I saw somebody put in the chat the comparison between hospital beds and jail beds. I will tell you, from the perspective of somebody that employs people that have been incarcerated in federal prison and state prison, they are the first to tell you they had more freedom in prison than they would have ever had in a psychiatric hospital. And so I don't want to just pass by that sentiment, because I hear it all the time, is that you have more freedom in due process. You know when you're going to be released from a jail or a prison. You have more representation. You've been charged with something, and yet the conditions that people often experience in psychiatric hospitals have a lot of inhumanity and less rights, less privacy than you have when you're incarcerated in a jail or prison. So I would be remiss if I didn't didn't name that. So in addition to my professional experience, I do create alternatives to psychiatric hospitalization in my work. So I'm actively working to find other ways to support people through extreme distress and extreme states without defaulting to involuntary treatment or confinement, handcuffs, and shackles as segregation, restraint, all of those things as the way we have understood how we treat people experiencing mental health crises. The other bias I'm bringing to this is I am a suicide attempt survivor, and my suicide attempt came directly as a result of a threat of an involuntary commitment. And so literally I was threatened with an IVC from my clinical team, and I was able to evade the IVC, but I turned around and I attempted suicide. And very similar to the quote that was shared, for me, I truly would have rather died than to be subjected to what I would have been subjected to during involuntary commitment. And here's the reason. It wasn't the handcuffs and the shackles, the police escort. It actually wasn't that. I am privileged to not have that level of fear and experience with police involvement like a lot of my colleagues and friends do. So that wasn't my fear. For me, it was getting to the hospital and being strip searched, body cavity searched, being watched while I bathe and while I pee. I came into this mental health system at the age of 13 as a sexual abuse survivor. And the entire time I was in services, which was a very long time, my behavior was translated through the lens of diagnostic criteria. So I ended up with, I don't even know how many mental health diagnoses. I lost count at 8. But I was seen as, my behavior was seen as pathology. The entire time I was in services, none of the adults saw or even asked the right questions to understand that what they saw clinically as my behavior was actually the manifestation of sexual abuse. And so fast forward to get to the point where I was being IVC'd. As a sexual abuse survivor, when I was able to be free of that threat, I made a commitment to myself that I would never allow myself to be that vulnerable again. Now, I recognize the faulty thinking. I never allowed myself to be vulnerable in the first place, but I certainly would never voluntarily allow myself, my body, to be in that level of vulnerable spot again. And when they said IVC, the panic that came over me around people that I don't know looking at me naked, strip searching me and body cavity searching me and watching me bathe while I peed, was this trauma response that I had where it was this instantaneous, I would rather die. And it led to a suicide attempt. So as you said, Dr. Shields, not only does this type of carceral care post-release increase suicide rates, right? So we think we're creating safety mechanisms, and in the short term, the immediacy, perhaps we are, but in the long term, upon release, we're actually doing the opposite and exacerbating it. For me, I attempted suicide on the front end because of the threat of an involuntary commitment. As I do this work with professionals throughout the country and doing the international work, what I recognize is people don't stop and think through what involuntary commitment means, what the process is going to be experienced like for the person, how that process is going to exacerbate whatever mental health issues that they're coming to us with. If they are a trauma survivor, and we know the majority of us are, how it magnifies and multiplies the trauma response, how removal of rights should be the absolute last resort, not the first resort when everything else fails, and then how on the back end, people are walking away so harmed that they're refusing any voluntary treatment. I operate an organization that almost solely works with people who have been kicked out of mental health services or have walked away from mental health services because they've been so harmed. I have an entire organization and career that is dedicated to the people who refuse mental health services but need safety nets and need opportunities to heal and recover and thrive with the experiences that they've had. And on top of it now, they've experienced harm by our services and systems. I know for myself, when I got into this work professionally, my commitment was to not harm people. And even more than that, I wanted to be there to support people, to find their voice and their identity outside of being a mental patient or an addict or the homeless or a felon, all the labels that we get in services. And so not only do I not want to do any harm, I want to perpetuate greatness, right? I want people to be inspired to live a full life. And what I find is that is just not the case within a lot of these systems, the hospital just being one. I'll leave with this because I don't know how much time we have, but I'll leave with this. This happened in December, as a matter of fact. We do a lot of work with folks that are involved in the DOJ settlement that are in institutional care to come out of hospitals. And in December alone, we had somebody in the name of treatment was involuntarily committed by their ACT provider because they said they wanted to work. Now, I will tell you, I see this misuse of power on a routine basis. It happens all the time. We remove people's rights. We say that what we are seeing is pathology, that the only way to safely serve that person is to confine them or remove their rights in some way. And it was somebody that said he wanted to go to work. And his treatment team said that was a sign of psychosis. And they had him involuntarily committed, and the hospital kept him for 30 days. These are illustrations in real time of how we are misusing what should be the least used approach and how they're being used on the front end.
Thank you, Shireen. First of all, thank you so much also for sharing and being vulnerable to the entire audience about those experiences and those pieces. And they touch into what Dr. Shields talked about related to the weak accountability on the caring side and being able to measure that and have accountability for that. And appreciate all the work you do and being a voice to improve that for everyone. Also, I think we're going to have on the roundtable Dr. Pinels from NASHPD and our senior medical forensic advisor there, and then Deb, if you could make a few brief comments, and then we'll actually jump straight into the NASHPD update.
Awesome. Well, thank you, Chuck, and thank you, Shireen and Morgan. I really was inspired by hearing the presentation, Morgan, and I thought every inpatient unit across America needs to hear your data. I think it's really compelling. I just want to speak from my own lived experience, which is not as a patient in a psychiatric hospital, but as a treater in a psychiatric hospital and somebody who oversees systems and looks at a lot of those rights complaints and really tries to think about how to improve services. I think the people going into the care of the psychiatric patient, for the most part, of course, there's always some wrongdoers, but for the most part are going in to help the people that they're serving. And so to hear that they're not helping is something that's really powerful, and yet can create also a sense of their own hopelessness and despair about how to help people who may not be in the right space to receive the help, or they might not be delivering the care in the way that helps people who aren't in the right space, which we understand is why people come into psychiatric care. So we have to shift. We have to shift the way we provide the care and really listen carefully to the voices of people with living experience, and still recognize that there are moments of incredible, I can think of my own, moments of incredible connection, like with the words of William Styron, incredible connection between treatment provider and the person receiving treatment. And that's what we should be striving for. And really thinking about, I've been spending a lot of time as a forensic psychiatrist working with people in some of the darkest times and some of the darkest places, to really say that our alliance as a human is really our hope. That's really where we can get recovery to happen and meet on both ends of trying to provide the care that people want and that is helpful. And so I think this data is really powerful, and it really gives us an opportunity to leverage your voices to think about how to meet in that space together, to provide people that hope, and the providers, the caretakers who are there to help deliver care. So I really appreciate that. I know we might be out of time, so I'll leave my comments at that.
You can move into NASHPD. We've got some time built in, so you don't feel rushed to do your NASHPD update, Deb.
Okay.
Great.
Okay, great. All right, so I'm now doing the NASHPD update, and one of the things I want to focus on, and I'm not sure if my slides made it to the deck. Yeah, Yep, they did. So I think Dr. Shields already talked about this, that we know that inpatient services are there for people who do present risks. There's a lot of inpatient people who come in because of their suicidal thinking. There's people who might be at risk for violence towards others. And there's people who are also struggling with co-occurring substance use challenges, who have been off their medications, and whose symptoms are more overt, or who need some adjustments to their medications. And so when people leave inpatient stays, as Dr. Shields pointed out, there is a very high risk that things can go awry. We know in the suicide literature, the period of time following hospitalization can be a period of high risk for suicide. I think there's lots of theories why that is. One could be some of the iatrogenic harms of the hospitalization. Another could be some of the failure to provide linkages and supports for people who are vulnerable, because there's no magic to 10 days or 3 days or whatever it is to being confined in a space that's going to in and of itself kind of cure the problems that people are facing. So we really need to think of this intervention as an opportunity to build longer term connections for people. Same with the risk of violence. Probably the best published, the best known study that had the most robust methodology for risk of violence post hospitalization for civil patients hospitalized under civil, not forensic conditions, showed that the first 10 weeks was a period of high risk for harm to others, again, potentially related to the instability of the environment in the community, where people are discharged to, and the like. We know that relapse on substances is huge. With the opioid crisis, we're learning more and more about discontinuity of care and what that means for death rates related to especially opioid use disorder. And then medication non-adherence. People may agree to take medications because they sense that in the hospital they feel pressured. When they leave the hospital, they may not continue with the medication that was prescribed to stabilize them. People may not feel empowered because of their own histories to describe side effects they're having. They may feel their own, the power dynamics make it too difficult to really be in there as a partner, as a patient with the prescriber. So there's the risks following inpatient stays are incredible. Crisis stabilization units will have the same challenges, and the crisis system often becomes the default for helping people who are still in a destabilized state. So we really need to think about the continuity of care, not that hospitalization is the be all end all, we're done, but what happens if this is one intervention, what happens post-hospitalization? Next slide. This is not a new thought. This has been talked about a lot. In 2017, we at NASHBID wrote Beyond Beds, this concept of the vital role of the full continuum of psychiatric care. And this was not a thought that just emerged in 2017 either. This is a long-standing recognition that we need this continuum, this idea that services, that people, we're with people to hold their hand on their journey throughout their needs as people receiving mental health services. And even when they're no longer in need of mental health services, that there needs to be support, and the continuum of care has to span from prevention to intervention. Next slide. And in 2017, we came up with many recommendations that are still as vital today as part of that vital care continuum, that there are outpatient supports and inpatient services that are too unevenly distributed and operate in silos rather than collaboration. Policymakers should recognize that mental health, community, justice, and public service systems are interconnected, and they should adopt and refine policies to identify and close gaps between them, which includes providing warm handoffs and other necessary supports to help individuals navigate between systems in which they are engaged. And I think talking about Trieste, which I have not been to yet, but I'm looking forward to being there, one of the big things that they talk about is this, it's a whole community, serving the community and providing the services that people need when they need them. So yeah, there's 6 beds. when people need inpatient care. I am a believer that some people, just like with medical conditions, will require inpatient services to help in that moment in time. But that's not the end of the story. We have to build the linkages and supports for continuity. I see too often as a forensic person, and somebody wrote about the wait list, one of the problems is we see disrupted episodes of care. So somebody gets started on medicine, they go off their medicine, they're in a different environment. Nobody understands what the story is behind them, their narrative, their personal journey. And it just becomes, for people with challenges and illnesses and histories of disruption, non-attachment, non-trusting relationships, and then mental state changes. When the system is chaotic and the person's internal state is chaotic, of course we're going to get failures, and we need to do better at creating those linkages. And that's where I wanted to end, Chuck.
Thank you, Deb. That's fantastic. It would help if I unmuted. I said, thanks, Deb. That was fantastic information and very important in pulling all of this together. Just so you're aware, we've got the state map that is continuing to update and look at different states. And NAMI is moving to a new methodology in this of looking at the level of connection in terms of comprehensive pending legislation funding as they're looking at their reimagined crisis org.map and at tracking that. And that's linked in the chat if you'd like to be able to see it more in depth. And now we go to Sarah Corcoran for our update on the federal side.
Thank you, Dr. Chuck. So I have a few updates from Capitol Hill. First, for the nomination of Dr. Oz as CMS administrator, that has been procedurally teed up to be considered in the Senate for the full Senate floor vote, final vote, sometime in the coming days. It was teed up procedurally last night, so we will expect that full vote sometime in the probably next week. We've got two committee updates as well. First, we'll start on the House side. The Energy and Commerce Committee has announced a markup of 20-something odd bills across multiple issue areas next week. That will be April 8th, Tuesday morning. And in particular, the reauthorization bill for the Support Act is included in that markup. Many of us will recall that as the landmark opioid focused bill from 2018, I believe. And it's up for reauthorization, so that will take an important markup step next week in the House. And then my final update is on the Senate side. The HELP Committee, also known as Health, Education, Labor, and Pensions, so helpfully it's the HELP Committee, has invited Secretary Kennedy to appear before the committee on April 10th to talk about the proposed HHS reorganization that was referenced earlier in the JAM with the announcement from Secretary Kennedy. That letter has been signed by both Chair Cassidy as well as Ranking Member Sanders to invite him to come and testify before the committee. I will share in the chat the press release for that letter on the HELP side, as well as the announcement of the Energy and Commerce markup for next week. If there are any questions, happy to answer them in the chat. But for now, I will turn it back to you, Dr. Chuck. Thank you.
Thanks so much, Sarah. And now, so I'd like to introduce Tina, someone from Listen, and she's going to talk to us a little bit about the implications of more accessible AI and specifically with DeepSeek and some of the thoughts behind that. Really looking forward to hearing about this, Tina.
Thank you so much, y'all. I have the privilege, too, of calling in from AAS in Columbus, Ohio, and in addition to feeling very grateful for hearing folks' lived experience, professional experiences of working at inpatient centers and centering patient care and health and safety I feel so grateful for the grounding in the work that we're doing, what we're striving towards, and why we're coming together as a community to really build the future for our patients who really need us. So that has been humbling, and I've been really grateful to sit on this call for the last 54 minutes and hear that and be at this conference. So thank you all for that. I'm going to talk a tiny bit about DeepSeek. This is a new AI, open source AI company that is coming out of China. If folks have looked at different social media, if you happen to have read the DeepSeek large language model paper, I myself have only gotten through the abstract. It's quite dense and intense. But if you're starting to see that there are new and innovative AI models, and these models are open source, that are coming out and really starting to overtake how much money has been used to build models like ChatGPT, Llama, and these other kind of multi-million-dollar companies that are building AI models for hundreds of millions of dollars. DeepSeek claims to have built their models for about $6 million. What this means, and you can go to the next slide, Karen, what this means for us is that there are going to be a lot of more affordable options for AI-based services and products. And I'm thinking about, too, as we're trying to innovate our hospital systems, we're innovating patient care, there likely will be more technology that's being integrated into those systems. And we need to continue to be vigilant and careful. There are hundreds of state-level bills that are being passed in order to center humans, clients, guests, and center human services to try to protect folks and regulate the use of AI. And I think as critical thinkers, I want us to engage what it means to have really safe, secure, equitable technology that's available for a lot of folks. The pros being that a lot more universities, small businesses are going to be able to innovate different products that are AI-based at a lower cost because of these new open source developments. The cons being that we need to be extra vigilant on how are these models trained? Are they applicable? What is the applicability for crisis care, inpatient care? Are these products actually doing what they're doing? And I want us to remember that also cheaper is not always better. Again, cheaper can really increase our accessibility, and we really, again, want to center patient care. We want to center guest care. We want to center the human experience in that, so that we're choosing products for our community that are AI-based, that are really the best for people and not necessarily the best for companies. Next slide, Karen. So again, I want us to engage all of our critical thinking skills. I want us to really rely on our state regulatory bodies, learn what's happening in your state in terms of AI regulation. Though there is a push for AI and innovation at the federal level, I want us, again, to center humans, center care, and center our communities when making these decisions about what products to choose, what businesses to purchase from, and are they holding the values that we want them to hold in terms of what types of products they're creating and how they're using their AI, where their data is going, and then questions about who is labeling their data and is this applicable for us. So I'm going to turn it back over to Chuck. Thank you so much for these couple minutes to talk about DeepSeek. If you have any questions about AI, we're always happy to talk about it at Listen. You're welcome to reach out and email me, and my email is on the last slide.
Tina, we have 1 minute before I go into the close. I just wonder, do you have any thoughts or any particular story that you could give it as an example to help illustrate some of the questions or ethical considerations? Is there anything that's been out there that would kind of illustrate that, things that have been success or things to watch for?
Yeah, I think one of the pieces that I've been considering a lot is who is labeling our data. And so we can have anywhere from, an example would be at Listen, we have human annotators that they're paid $50 an hour to annotate data. They are licensed and trained clinical practitioners, they're psychologists, they're CMHC, master's level clinicians. These folks are really trained to do patient care and then are labeling data with that licensure, education, and intentionality in mind. And they are paid a wage that is appropriate for the type of work that's happening. On the flip side, what could be happening, much like when we are hiring or when we're outsourcing phones, when we're outsourcing clothing production, we can outsource to organizations and countries with different types of labor laws or a lack of labor laws, where folks are not being paid for their time in labeling AI-based data that's then being used to feed these large language models. We're really unsure of how these folks are trained, the content of what they're labeling, and then their personal kind of work conditions and how they are being treated as individuals. So all of that, I think we need to be really careful about, and something that's really at top of mind for me.
Thank you so much for that example, Tina. I appreciate it. Thanks again for being on the Tech Corner. So coming soon, our next episode will be in episode 212, will be another fireside chat feature with the guardian of the Golden Gate Bridge, Kevin Briggs. Really excited to have him. I think he was here 5 years ago, so it'll be great to have him back speaking about the work that he does. And then, like I said, 2 weeks from now, we'll have our debate between Justin and Preston about mobile crisis should always be dispatched by local 988, yes or no. In close for today, oh, what a great topic, for our crisis learning community. No matter what layer in the continuum that we're talking about, the focus that Dr. Shields brought on thinking about caring and a humanizing experience, but being accountable to that. I think the chat showed many ways and ideas of how that could happen. And as Dr. Shields illustrated, there's lots of areas on the spectrum of either abolish the whole system because it can't work, or in the middle, trying to find some kind of synergy, or what I like to call fusion, of pulling in the best elements of both things. It's always going to be a challenge to do that, but having systems in place like Dr. Shields exhibited today that helps measure the effectiveness of it and what works and doesn't work is really important in our field, so that we can start evolving and continue to improve best practices in the way people are cared for, not just in crisis, but in all of healthcare, especially in the mental health and substance use spectrum. So really appreciate everyone's engagement and discussions today. They were meaningful to me. I hope they were meaningful to you. And thank you so much. And we'll be signing off and seeing you next week on episode 212.